Hi everyone, and welcome to our second module on labor and delivery. Let's start by talking about induction of labor. So many women spontaneously go into labor, but if this doesn't happen, or if you want it to happen sooner, you can induce labor by administering medication. So the term induction of labor refers to the stimulation of uterine contractions prior to the spontaneous onset of labor, and it's done by the intravenous administration of synthetic oxytocin. Usually this is done after a woman has spontaneously ruptured her membranes if she has not yet started labor, or after an amniotomy, which is when the membranes are manually ruptured by a provider. And so some of the common indications, some of the reasons why we induce labor is, first of all, if a pregnancy has entered the post-term, which is beyond 42 weeks. There are risks to both the mother and the baby if pregnancy enters the post-term, so before this happens, labor can be induced. We also often induce labor in women who have premature rupture of membranes. So if the membranes rupture but the woman hasn't entered labor, then we can induce labor with oxytocin. If there is intrauterine growth restriction or oligohydramnios, in both of these situations there can be risk to the baby, so often labor will be induced. Importantly, however, induction of labor is not done for fetal distress. When the baby is in distress, you have to do a C-section and get the baby out as quickly as possible. Induction of labor is only done when the baby is safe and stable, but there are elements like these things listed on this slide which make it dangerous for the pregnancy to continue. Before you can induce labor, you have to check the cervix to make sure that the cervix is favorable or ripened for delivery of the baby. The idea here is that you don't want to administer oxytocin and induce labor if the cervix is closed because the baby won't be able to get out. And the usual definition of a cervix that is favorable or ripened for induction of labor is a Bishop score greater than 6. I talk about the Bishop score in the first video on labor and delivery, but basically it's an assessment of various elements of the cervix to determine the preparation for delivery of the baby. If the Bishop score is low, there are a couple of so-called cervical ripening techniques that can be used to prepare the cervix for the induction of labor. One is to administer misoprostol. Misoprostol is a prostaglandin E1 analog, and it can be used to cause uterine contractions, but it also can be used to ripen the cervix. It can be given as an oral drug or it can be given vaginally. There are also a couple of prostaglandin E2 gels that can be applied vaginally. One's called Prepradil, the other's called Cervidil. And then lastly, there are mechanical dilators that can be used. Augmentation of labor is different but related to induction of labor. Augmentation of labor refers to oxytocin administration during the active phase of labor. So this is done in women who have already entered labor but they have inadequate uterine contractions or prolonged labor, and you want to help the labor along by administering oxytocin. Oxytocin has a number of adverse effects you need to be aware of. The first one is tachysystole. This basically means too many uterine contractions. The technical definition of tachysystole is more than 5 contractions in 10 minutes averaged over a 30-minute period. And when the contractions are this frequent, it can cause fetal hypoxemia or acidemia. It can also potentially cause uterine rupture. So when a woman in labor is receiving oxytocin and she has evidence of tachysystole, you can reduce the dose, stop oxytocin, or in some cases administer terbutaline, which stops uterine contractions. Oxytocin can also cause hyponatremia. If you look at its structure on the screen here, you can see that it has a very similar structure to antidiuretic hormone. So it can have the same effects as ADH and cause the retention of water, and that can lead to hyponatremia. Oxytocin can also cause hypotension in the mother. That's because it relaxes vascular smooth muscle. And then finally, you should be aware for your rotations that oxytocin commonly causes maternal fatigue or sleepiness. This is one of the things you will most commonly see in women receiving this drug. Analgesia and pain management during labor and delivery is usually via neuraxial anesthesia. This refers to either spinal or epidural anesthesia. Drugs that are commonly used are local anesthetics, usually bupivacaine, and opioids like fentanyl. And I talk about all of these things in more detail in videos in the anesthesia section. A cesarean delivery, also called a cesarean section, refers to surgical delivery of the baby. And there are a number of maternal and fetal indications. One of these is failure to progress of labor. We'll talk more about this later on in this video. Another is one I already mentioned, which is fetal distress. Women who have multiple gestation pregnancies with twins or triplets often require a cesarean delivery. And then if the baby is very large, in other words, if there's macrosomia, sometimes the baby cannot be delivered vaginally and a cesarean delivery is required. Usually cesarean deliveries are done with a transverse skin incision. That's what's shown on the slide here in this picture. And then once you make the skin incision, you have to make an incision in the uterus in order to get the baby out. And ideally, this is done through what's known as a lower uterine transverse incision. This type of uterine incision, after it heals, carries a lower risk of uterine rupture with subsequent pregnancies. And so after a cesarean delivery, if the woman has another pregnancy and she wants to deliver vaginally, that can sometimes be done if the initial cesarean section was done through a lower uterine transverse incision. The other type of uterine incision is called a vertical or classical incision. This carries a higher risk of uterine rupture with subsequent pregnancies, and so women who have an incision like this made in their uterus cannot attempt a vaginal delivery in subsequent pregnancies. The major long-term complication of cesarean delivery is that there will be uterine scarring, and in subsequent pregnancies this raises the risk of certain adverse outcomes. There's a higher risk of uterine rupture, also placenta previa and accreta, and also placental abruption. So because of these risks, women who have a cesarean delivery often have subsequent pregnancies also delivered by C-section. Some women, however, desire a vaginal delivery after they've had a prior C-section, and this can be done in certain cases. A TOLAC means a trial of labor after cesarean, and a VBAC refers to a vaginal birth after cesarean. And as I mentioned on the last slide, if a woman has a cesarean section with a vertical classical incision, then she can't do a VBAC in subsequent pregnancies, and that's because the risk of uterine rupture is too high. In the first video on labor and delivery, I talk about the stages of labor, and I also talk about the normal duration of those stages for women who are either nulliparous or multiparous. So an abnormal labor pattern refers to any time the duration or the progression through a labor stage is abnormal. Protracted labor means a prolonged phase of labor, and labor arrest means there's no progress through a labor stage. So in the first stage, this usually means no progression of cervical dilation. And clinically, when you're on your rotations, you'll sometimes hear the terms used failure to progress or dystocia. These are just other ways of describing labor patterns that are not normal. And it's important to recognize abnormal labor patterns because they may require augmentation of labor or cesarean delivery. Shown on this slide is a graph showing the centimeters of cervical dilation on the y-axis and the number of hours of labor on the x-axis. The first phase of labor ends when the cervix is about 4 to 6 centimeters dilated, so normally that would occur here, and then there's rapid progression through the remainder of the first phase until the cervix is completely dilated at 10 centimeters. So shown at the bottom in these dotted red lines here is what a protracted latent first phase of labor would look like. Basically, the cervix is just taking forever to get to that 4 to 6 centimeter threshold. And then these other red lines show abnormalities of the active phase of the first stage of labor. If the active phase is protracted, that would look like this. The cervix is increasing its dilation, but it's just taking a long time. And then arrest of the active phase would look like this. There's simply no progression in the amount of cervical dilation. So the first stage of labor, like I said in the last slide, is divided into a latent and active phase. The definition of a protracted latent phase of the first stage of labor is a prolonged amount of time required for the cervix to reach 6 centimeters in dilation, and the definition is more than 20 hours in a nullogravida woman, more than 14 hours in a multigravida woman. A protracted active phase means a prolonged period of time for the cervical dilation to progress beyond 6 centimeters all the way to fully dilated at 10 centimeters. And the definition of a protracted active phase is if the dilation progresses less than 1 centimeter per hour. And then you can also have a rest in the active phase of the first stage of labor. The definition is no cervical change for more than 4 hours in a woman who has adequate contractions, or no cervical change for more than 6 hours in a woman who has inadequate contractions. The most common cause of abnormal labor patterns in the first stage is that the uterine contractions are weak, otherwise known as hypocontractile uterine activity. And we can actually quantitatively monitor the uterine contractions using an internal pressure catheter after membranes have ruptured. The catheter can be inserted into the uterine cavity, and we can monitor the baseline pressure in the cavity and the pressure generated by each contraction. We quantify uterine contractions using something known as Montevideo units, or MVUs. These are defined as the peak uterine pressure from a contraction minus the baseline. So if you look at this graph on the screen, this is showing the data from an internal pressure catheter in the uterus during labor and delivery. The baseline pressure is 20, the peak pressure with a contraction is 70, so the Montevideo units for this contraction would be 70 minus 20, or 50. And normal is greater than 200, so when the MVUs are low, this is associated with abnormal first stage labor. You should also know that obesity is associated with a longer length of the first stage. The higher the BMI, the longer the length of the first stage of labor. Shown on this slide are some of the interventions that can be used when there are abnormal labor patterns of the first stage. So if there is a protracted active phase, which means the cervix is just taking a long time to become fully dilated, then infusion of oxytocin plus amniotomy can be done. We'll talk about amniotomy in a minute, but it's a manual rupturing of the membranes, and this can be done if the membranes have not already spontaneously ruptured. And then oxytocin infusion can be helpful for a protracted active phase even if contractions are adequate. Sometimes stimulating the uterus to contract more vigorously can cause the cervical dilation to improve. If, however, you have active phase arrest where the cervix has simply completely stopped dilating, then in those situations usually a cesarean delivery is necessary because vaginal delivery is not going to be possible. And then the latent phase is always a very long phase of labor, and if it is prolonged, the management in these situations is complex. Sometimes these women will be discharged home and told to come back to the office to see if they are progressing the next day. Other times they can be admitted as inpatients and administered oxytocin. In the second stage of labor, the cervix is fully dilated. This is sometimes called the pushing stage because this is when the mother is pushing the baby out of the womb. So causes of abnormal labor patterns in this stage usually have to do with abnormalities of the baby fitting its way through the pelvis and out of the womb. One of the reasons this can happen is if there is cephalopelvic disproportion. This refers to a mismatch in the size of the fetus relative to the maternal pelvis. You can also have an abnormal second stage if the fetus is malpositioned. The most common fetal malposition is occipito-posterior. That's what's shown in this image on the slide here. This is how the baby should normally be positioned in the pelvis, but if it is positioned this way, this is called the occipito-posterior position, and it's a form of malposition. Basically, the back of the head of the fetus is towards the mother's spine instead of towards the front of the pelvis. You can also see an abnormal second stage if the uterine contractions are inadequate. And then finally, because the mother is pushing in this stage, poor maternal efforts can potentially lead to an abnormal second stage. Now, most obstetricians carefully advise mothers about when to push so that they can rest and only push when absolutely necessary. So if you've properly advised a woman, poor maternal efforts are very rare, but nevertheless they are on the list of potential causes of abnormal labor in the second stage. Some of the interventions for abnormal labor in the second stage are shown in this slide. So once again, you can use oxytocin to increase the strength of the uterine contractions. And then in the second stage, when there's abnormal labor, this is when operative deliveries are sometimes required. This refers to using either forceps or a vacuum to try and help the baby get out. This is a picture of using forceps for an operative delivery shown on the screen here. And then lastly, in the second stage, sometimes if labor won't progress, a cesarean delivery is necessary. Let's talk about rupture of membranes. This refers to rupture of the amniotic sac. This presents as vaginal fluid leakage. Classically, women will feel a gush of fluid when the membranes rupture. The fluid is usually clear or pale yellow. However, if meconium has passed in utero, then you can see green fluid when there's rupture of membranes. The membrane rupture can occur spontaneously after the onset of labor. This is called an SROM. It can also occur before the onset of labor. This is called pre-labor rupture of membranes, or PROM. Sometimes the rupture of membranes occurs before 37 weeks, which is premature, and before the onset of labors. This is called a PPROM. And then lastly, as I mentioned earlier, sometimes it's necessary to artificially rupture the membranes. This is called an amniotomy or an AROM. So when a woman is approaching term and she has vaginal fluid leakage, you need to confirm that that fluid leakage represents rupture of membranes. It could be due to other causes like urinary leakage or discharge. So there are a couple of tests that can confirm that the membranes have ruptured. One is called the nitrazine test. In this test, you take a sample of vaginal fluid and you put it on nitrazine paper strips. The idea here is that amniotic fluid has a high pH in the range of 7 to 7.3, and this will turn the nitrazine paper strips blue if the pH is high. This is a picture of nitrazine paper on the screen here, and if you apply some vaginal fluid and it turns it blue like this, that indicates a high pH, and that's what you see in women who have ruptured their membranes. Another option is the Fern test. The idea here is that vaginal fluid gets mixed with high levels of estrogen in the amniotic fluid when the membranes rupture, and this causes the fluid to take on a fern-like pattern when you examine it under the microscope. This is a picture of what vaginal fluid after rupture of membranes can look like. You can see it looks like a fern pattern. And then lastly, there are some dye tests that are used in certain special situations. The idea here is to inject dye into the amniotic sac through the abdomen, and the colored fluid will appear in the vagina if membranes have ruptured. Pre-labor rupture of membranes is a special situation. This refers to the rupture of membranes prior to regular uterine contractions, and it occurs in up to 15% of pregnancies after 37 weeks. So these women rupture their membranes before they've gone into labor. And the risk to the woman in the pregnancy here is that there's an increased risk of infection once the membranes have ruptured. Chorioamnionitis may occur if this is allowed to go on without delivering the baby for a long period of time. If you think a woman may have ruptured her membranes before going into labor, the way you diagnose this is through a sterile speculum exam plus testing of the fluid. So a key point is you don't want to do a digital exam because you might introduce bacteria and cause infection. So you do a sterile speculum exam and you obtain fluid that you can test with the nitrazine test and the Fern test. Also, cultures are often obtained for Neisseria and group B strep because infection with these agents is associated with pre-labor rupture of membranes. Once you identify that the membranes have ruptured before the onset of labor, there are two options going forward. Expectant management is to await the onset of natural labor, and active management refers to the induction of labor with oxytocin. And one of the common reasons to induce labor is if pre-labor rupture of membranes has occurred. Let's talk about post-term pregnancy. So pregnancies are called late term if they've gone beyond 41 weeks without the onset of labor. A post-term pregnancy is a pregnancy that goes beyond 42 weeks without the onset of labor. And when pregnancies go on this long, there's a risk of macrosomia, meaning a very large baby, also the dysmaturity syndrome, and a number of causes of perinatal mortality. And I talk about all of these things in more detail in videos in the pediatrics section. So because we want to avoid all of these things, usually labor is induced at 41 weeks if a woman has not spontaneously gone into labor on her own. And as she approaches this late-term period, usually regular non-stress testing is done, as well as measurement of the amniotic fluid index. A big problem with these post-term babies is that they can be associated with oligohydramnios, which is associated with poor outcomes. So as you're monitoring the baby approaching the late-term period, if you identify oligohydramnios, that's usually an indication to admit the woman to the hospital for induction of labor. Let's talk about group B strep infection. So group B strep commonly colonizes the female genital tract, and for this reason, it's a frequent cause of pregnancy-related infections. It can cause asymptomatic bacteriuria, and I talk about this in other videos. We always screen for this early in pregnancy. Group B strep can also cause urinary tract infections, chorioamnionitis, which we'll talk about in a minute, postpartum endometritis, which I talk about in the video on postpartum problems, and also sepsis in newborn babies who acquire this infection when they pass through the birth canal. The best way to diagnose group B strep infection is through urine culture, but this takes a day or two to come back. So if you need to quickly know whether or not a woman is group B strep positive, the preferred test is nucleic acid amplification testing, or NAAT. This test amplifies DNA or RNA sequences to identify group B strep infection, and it gives you rapid results, usually in less than 2 hours. It's less sensitive than culture, that's why a urine culture is the preferred test, but if you have a woman in labor and you don't know her group B strep status, this is the test that you want to use, and that's because it will come back quickly. Because a baby can acquire a group B strep infection during a vaginal delivery, we administer intrapartum antibiotics in women who are having vaginal delivery if they're at high risk of having a group B strep infection passed on to the baby. The major indications for antibiotic prophylaxis during labor and delivery are shown on this slide. So first of all, any woman who's had a positive screening culture during pregnancy gets antibiotic prophylaxis. Also, any woman who previously had an infant that developed neonatal GBS disease. Any GBS infection that's identified during pregnancy and treated gets antibiotic prophylaxis. And then lastly, if you don't know the woman's GBS status, but she has one of the following, she should receive antibiotic prophylaxis. This includes fever over 100.4, preterm labor, preterm pre-labor rupture of membranes, prolonged rupture of membranes more than 18 hours, or a positive intrapartum NAAT test. Remember I said that this test is often used to identify women when you don't know their group B strep status at the time of delivery. When there's an indication for intrapartum antibiotic prophylaxis to group B strep, ideally you administer the antibiotics at least 4 hours prior to delivery. The first-line drugs are either penicillin or ampicillin because both of these rapidly accumulate in the amniotic fluid. If the woman has a penicillin allergy, then what you do next depends on the severity of her allergy. If she has an allergy that suggests a low risk of anaphylaxis to penicillin, for example, a woman who had a rash to penicillin in the past, then the drug that you can use is cefazolin. If, however, the woman is thought to have a high anaphylaxis risk to penicillin or ampicillin based on prior reactions, then the next step is Group B strep isolate testing. You want to take one of the Group B strep isolates from the woman and determine the clindamycin sensitivity. If it's sensitive to clindamycin, you can use clindamycin, but if it's resistant, you can use vancomycin. And the idea here is that in penallergic patients, we often use clindamycin as a backup drug, but you can't do that in the case of Group B strep because the frequency of Group B strep resistance to clindamycin is very high. So you need to figure out whether or not you're dealing with a resistant species. And then lastly, when women have an indication for intrapartum antibiotic prophylaxis, you often try to avoid a fetal scalp electrode. A fetal scalp electrode is introduced through the cervix and placed on the scalp of the baby, and this can increase the likelihood that the baby develops an infection. And then the final topic for this video is chorioamnionitis, which is also referred to as an intraamniotic infection or an IAI. Chorioamnionitis means infection of the chorion, amnion, and the amniotic fluid, and it usually occurs after rupture of membranes. And in fact, the most important risk factor for development of chorioamnionitis is the duration of rupture of membranes prior to delivery of the baby. And this is one of the reasons why when women have pre-labor rupture of membranes, we often induce labor so that they won't have a long period of time where the membranes are ruptured and infection could occur. Usually chorioamnionitis is polymicrobial. It involves gram-negatives, gram-positives, and also Group B strep like we just talked about. It's usually diagnosed clinically. We'll talk about this in a second, but the gold standard is a gram stain and culture of the amniotic fluid showing the presence of bacteria. The clinical features of chorioamnionitis include fever, maternal leukocytosis. The mother can develop an increased heart rate, and so can the fetus. So in the differential diagnosis for a fetus that has persistent tachycardia, like shown on the screen here, is the possibility that the mother may have chorioamnionitis. The uterus can become tender on exam. Sometimes there is purulent or malodorous amniotic fluid. And then in rare circumstances, women can develop bacteremia from chorioamnionitis. This usually happens when the cause of the infection is Group B strep or E. coli. So in a woman who has ruptured her membranes, who develops fever and a white count, the working diagnosis is usually chorioamnionitis, and the treatment is with broad-spectrum antibiotics plus immediate delivery. Usually there's prompt induction of labor or cesarean delivery. You should understand, however, that the standard indications for cesarean delivery apply. A vaginal delivery is safe if the mother and fetus are stable. You don't necessarily have to do a cesarean delivery. However, in many cases, because the uterus has infection, it doesn't contract well, and this leads to protracted or arrested labor, and then a cesarean delivery is required. The antibiotics that are administered intrapartum are usually ampicillin and gentamicin. This is a broad-spectrum combination. And then if the woman requires a cesarean delivery, usually clindamycin or metronidazole are added. That's because these two antibiotics have good coverage of anaerobes, which can sometimes cause postpartum endometritis. We sometimes administer prophylactic antibiotics to prevent the development of chorioamnionitis, and the main indication for this is women who have premature pre-labor rupture of membranes. These women rupture their membranes before term, and you often want to wait to induce labor so that the pregnancy can reach term, but that means a prolonged period where membranes are ruptured and infection can occur. So prophylactic antibiotics in some women in this group reduce the risk of clinical chorioamnionitis. They've also been shown to prolong latency and improve neonatal outcomes. Latency is the time between rupture of membranes and the onset of labor. And so I talk about PPROM in detail in another video, but just for our purposes here, you should know that prophylactic antibiotics to prevent chorioamnionitis are indicated for PPROM less than 34 weeks. They're not indicated in women who have PPROM after 34 weeks or women who have pre-labor rupture of membranes when they're at term. And that concludes our second video on labor and delivery.